Friday, April 9th. Thank you, members. For the record, we do have a quorum. And I'm going to ask Senator Draheim to chair. Our plan today is to move the A1 amendment, process any other amendments that the committee would like to have heard. And we have had public testimony on the amendments that were published prior to, were published for a hearing on Wednesday. We will not be taking public testimony on the DE or any of those amendments, but open to public testimony on the remainder of the amendments. I believe everything has been made public, but if not, we will have public testimony on any introduced amendments. So with that, Senator Draheim, if you could take the chair.
Thank you, Chair Benson, and good morning, everyone. Senator Benson, would you like to move Senate File 2360?
I move Senate File 2360.
And do you have an amendment?
Mr. Chair, I move the A1 delete everything amendment. And Mr. Chair, as an amendment to the amendment, I have the A16. This is purely technical, correcting drafting errors, so I would like to move the A16 amendment.
So, Senator Benson, we should probably move the A1 first and then amend on the A16.
Okay. Thank you, Mr. Chair. I move the A1.
Okay. We have an author's amendment, members. Please turn on your camera. All in favor of the A1 amendment, say aye.
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 Any opposed? Nay? To your amendment.
Thank you, Mr. Chair. I offer the A16 to correct drafting errors.
Okay. Is there anything that we should have council go through on this, or is it pretty straightforward?
Mr. Chair, they were recommendations from the Department of Human Services, so if the department would like to comment.
Okay. Anybody have any concerns with the E16 amendment? Senator Wickland.
Madam Chair, I guess if it could be, if the department could just clarify the reason for the language change on 1.4 and 1.5, I'd appreciate it, just understanding why that's being removed.
Thank you, Senator Wickland. And do we have someone here from the department that would like to comment on that?
Yes, thank you, Mr. Chair. Matt Burdick with the Department of Human Services. Give me one moment. I'm just pulling up the amendment for reference. And Senator Wickland, could you restate which two lines you're interested in?
I was just wondering, the lines 1.4 and 1.5, there's some language removed about federal and state funding and to be needing to be available. And I just wondered the reason for the removing that language.
Thank you.
Yes, thank you, Mr. Chair and Senator Wickland. The reason for this is that we have some issues around the federal approval of that. And we don't believe that CMS would allow federal funding for kind of the group as it was described. And so this is just to clarify, to align with some of the fiscal note assumptions to make sure that's clear.
Senator Wickland, does that answer your question?
Yes, thank you.
Yep, thank you. So members, we have the technical amendment E16 in front of us. Please turn on your cameras. All in favor of the A16, say aye.
Aye.
Aye. Any opposed, nay? Amendment passes. Senator Benson, to your amended bill.
Thank you, Mr. Chair. And then I do have a list of amendments that were made public. I'm going to move to the A5 amendment, and it is cost. We received a fiscal note. It appears to be cost neutral. And members, this was language that was published so that the number of reports that we discussed this on Wednesday, the number of reports that the legislature has requested, some of them don't have expiration dates. This would give notice to the legislature when reports were set to expire on a timely schedule, and that if a report wasn't given an expiration date, it would be assigned a time to expire. The departments do spend a lot of time on reports, and I think periodically the legislature should look at everything we've requested, decide if it still has value, and then ask the department to stop working on it. So I'm happy to answer questions, and I offer the A5.
Thank you, Senator Benson. Members, any questions on the E5 amendment? Senator Klein.
Thank you, Mr. Chair. And just a question and clarification for the author. So does this, for current reports that do not have an expiration date, does this now impose those dates? I'm just trying to understand the amendment. It's my first look at it.
Yep, I'm sorry, Senator
Benson.
Klein. Yes, it sets, and thank you, Mr. Chair. It sets a termination date of any report enacted before January 1st, 2021 expires on January 1st, 2023. And then if it's an annual report, if it's a biennial or less frequent report, we shift the expiration date to 2024. So the legislature would receive advance notice of what reports were expiring. We could decide to reinstate them. I'm going to give a nod to the department for helping me realize how much time is spent on reports, and we need to determine if there is value. That being said, every time we ask for a report, the department charges us money, but as we eliminate reports, the department doesn't charge us money or doesn't give us credit for money. So there's a little having it both ways with this amendment, but I'm fine to move the language forward. It helps the legislature re-engage and not waste time on things that the legislature doesn't value.
Thank you, Senator Benson. Senator Klein, did that answer your question? Okay, thank you. Members, we are on the A5 amendment. Any other questions or comments? If not, we are going to vote on the A5 amendment. Please turn on your cameras and your volume. All in favor of the A5 amendment, say aye.
Aye.
Any opposed, nay? Amendment passes. Senator Benson.
Thank you, Mr. Chair. I would like to move the A7 amendment. Again, this was made public as we invest in maternal child health. I want us to be looking at key measurements to see if we are reaching moms and babies and if we are getting better outcomes, and evaluating those by impacted populations as we talk about ongoing disparities. If we don't start paying attention to the work we do and whether it adds value or gets the outcomes that we expect, then we're just going to keep spending money and not solving problems. And so, members, some of the things on here, for example, experience an excessive blood loss of more than 500 cc's, that goes to maternal morbidity. And I know there are other proposals about maternal morbidity moving through the legislative process, but they require use of an individual's data, not population-based, even disaggregated data. And so my preference to get to concerns about maternal morbidity is to do so in a way that protects the data of the individual and looks more at our systems. The All Payer Claims Database is a robust resource, although there are some gaps. Happy to continue working on how we get the information we need to determine if our policies have impact. And so I have talked to several providers about the language that is in, or the benchmarks that are outlined here. We are struggling, however, to get a fiscal note. And so I want this committee to be aware, to debate, but I want you to know that I will be withdrawing this because we don't have this tracking on our spreadsheet. I'm going to add this in finance after we find out the cost related to this. So if we can have the debate and inform thoughts here, and then I can add it in finance where we might not have this level of expertise.
Thank you, Senator. Senator Klein.
Thank you, Mr. Chair, and thank you, Senator Benson, for including this provision, although I unfortunately won't be able to go forward today, but I understand you're serious about it, and it is I applaud it as a necessary first step, generating data and information for this legislature to comment and understand more thoroughly the problem of health outcome disparities, particularly in maternal and child morbidity and mortality in our state, which are appalling. I also commend the inclusion in this bill of 6 months of medical assistance care after birth, which will be a necessary first step in correcting those inequities as well. I would only make the comment, as long as this amendment is on the table, that this is really generating reports is something that is sometimes an excuse for inaction in the legislature. I don't expect that of this committee or of you, Madam Chair, but certainly this is a crisis long in the making and very urgently in front of us. And correcting it, reversing it will take more decisive action. So we look forward to those interventions.
Thank you, Senator Klein. Senator Wickland.
Thank you, Mr. Chair. Yeah, I'd like to say I'd also support, I think the idea of this report is a good one. I would just like to add that I think having the baseline, or having the metrics, the measurements, and then the baseline for the metrics and metrics data is something that could be helpful to the legislature, but we also really need to have the ability to interpret it. And I would appreciate having assurance that, that the report will then be, we will be able to have interpretation done by those who are closer to implementing the types of measures that we're hoping will reduce health disparities. So, people who are in the Department of Health and Department of Human Services who are responsible for implementing tactics to reduce health disparities, we will definitely need help with interpretation of the data. And so I guess I'd like to see this idea move forward. I would like to get some feedback from others outside of the, and I don't know if it's appropriate today, but just on the items that are included, are they going to be helpful? And are we going to be able to take actionable steps based on the data that's collected? And I don't know that if you've been able to receive some feedback on that, Senator Benson, or if there's anyone else who could comment on that. But in general, I think it would be, I think you're correct that we do often take steps, but then we don't necessarily analyze whether the steps are having the intended effect. Thanks.
Senator Benson.
Mr. Chair, and thank you, Senator Wickland. And I did talk to folks both at MDH and DHS, and I read the reports, but I couldn't determine if an action was taken and then there was an outcome from those reports. We track a lot of things, but I couldn't see action and then an impact. And so as I started thinking about it, what would be helpful to me as a policymaker, and you're all policymakers as well. And so if you think this should be done differently so that it's more useful for you, we are making purposeful investments. We started in 2017 with targeted home visiting. That's why the benchmark day or benchmark year of baseline year, of 2017 is in here. We are changing the way we do doula, both payments and cultural engagement. Is that going to have an impact for these families? If we're going to do home visiting, are those moms getting prenatal services? And there's language that says if a mom is using a substance, that they don't get turned over to child protection, because we specifically want them engaging in prenatal care. Do we reduce the primary cesarean rate because we have made investments in home visiting, midwives, and doula support? Are we seeing better birth outcomes by keeping babies out of the neonatal ICU. These are all things we can measure. And then I added a key morbidity measure, which is 500 cc's of blood. If a mom loses that much, was there a difference because she had a doula, because she was engaged in prenatal care? Was there a difference because she had someone walking alongside her during home visiting and then delivery? Are they following up after the birth of their child? So if we're going to make these investments in things that we all agree are important, then let's see if they have results. And this is an editable document. I don't want it to be 20 items that we measure because the legislature glazes over when you get to about 7, but I'm really trying to make this a practical document for us to evaluate the actions that we've taken and the investments that we've made. So I'm sorry, Mr. Chair, I see Senator Eaton has a question.
Thank you. Senator Eaton.
Thank you, Mr. Chair, and Senator Nelson, Benson. What I wanted to thank you for the 6 months postpartum coverage for medical assistance. I did want to point out that the infant gets a year, and 12 months would have been preferable, but I know the House only has 6 months. But the cost, the last figures I saw were somewhere around $3 million for the IT to change this. And if we're going to expand 12 months later, we would probably have to duplicate that cost. And so it might be worth considering doing it just once. But nonetheless, an extension to 6 months is admirable. Thank you.
Thank you, Senator Eaton. Senator Benson, any follow-up?
No, thank you, Mr. Chair. And I just want to say to members of the public and in particular members of this committee, if you see changes to the A7 that would make it more useful to you in evaluating the work that we're doing, please reach out. This isn't a political document. It's not even a positioning document. This is something that needs to be useful to the legislature. And with that, Mr. Chair, because we don't have a fiscal note, I'll withdraw the A7.
Thank you, Senator Benson. Did you want to go? I think you have one more amendment or two.
Mr. Chair, I have it labeled as the Utke amendment, but he is not on the committee. So, Mr. Chair, I'll move the A8 amendment.
Members, we are on the A8 amendment. Would you like to describe the amendment, Senator Benson, to the members?
Thank you, Mr. Chair, and I am actually looking for my notes on Senator Utke's language. And you know what?
I think there's an amendment to this amendment.
There is, and Mr. Chair, while I look for my notes, I'm going to offer the A17 to the A8.
Okay. So members, we should have the A8 and the A17 in your documents. So we are on the A8 and we are going to amend the A17 to the A8 amendment.
Mr. Chair, I move the A17 as amending the A8. And I believe that Julie Ellis and Brad Vold are available to comment. That might be better than me walking through talking points, Mr. Chair. The people who are engaged in this and have been shepherding will be more effective in forming the committee.
Thank you, Senator Benson. We'll go to the testifiers and then we'll come back to the amendments. I have Julie Ellis and Brad Vold, I believe. So if you would please turn on your cameras and state your name and who you represent for the record.
Thank you, Chair Draham and committee members. My name is Julie Ellis. I'm the Human Services Director with String Services. I will be the testifier today. Brad Vold was going to be my backup in case you didn't get to this part of the hearing in the time that I was available. So thank you for allowing me to testify. I'm here representing the Minnesota Association of County Social Service Administrators, or MACSA. Senator Benson described this amendment as two things. It creates an MA billable service that allows county workers to utilize a DHS-approved screening tool that would authorize up to 36 units of treatment coordination services for pre-treatment coordination. And it also allows counties to bill medical assistance for peer support recovery services. I don't want to rehash what counties have already shared with this committee, but I would just like to emphasize that counties feel this provision is incredibly important, not just to fill some gaps in our current substance use disorder treatment delivery system, but also an important tool to getting more individuals connected to a PMAP. Many individuals struggling with chemical dependency lack medical coverage. This prevents them from going directly to a provider to get a comprehensive assessment. Pre-treatment coordination services would allow counties to assist these individuals in accessing appropriate resources, including medical coverage. Best practices tell us that an individual is in a time and space to seek treatment, that is the time to act. We think it is important for counties to continue to be able to provide some assessment and pre-treatment coordination so that we're not turning away individuals when they're seeking treatment, knowing that they may not be able to readily access a provider in many parts of the state. We appreciate the committee considering the county priority, and I'm happy to answer any questions you might have.
Thank you, Ms. Ellis. Members, do we have any questions for the testifier? Thank you. Senator Wickland.
Mr. Chair, I'm just wondering if there are, is there any cost to this, or is it all going to be the MA part covered by federal funds? If you could just comment on that. Thank you.
Sure. Yeah, this is the first step to seeking CMS approval for those pre-treatment coordination services. We're very hopeful that CMS will approve them. If they do not approve those services, we have agreed to, and the department has agreed to continue conversations about what the funding source might be.
Thank you. Senator Eaton.
Thank you, Mr. Chair. I just want to thank everyone for this proposal. We heard this in licensing, HHS licensing, and it is crucial for people who are trying to seek recovery from addiction. The substance use disorder programs that we have now require great delays, especially if you're somebody who has an opioid use disorder. If you're going into withdrawals and you have to wait a week to get a Rule 25 assessment, you're not going to do that. You're not going to suffer withdrawals for a week. You've lost the opportunity to help that person. And that, in fact, happened to my daughter, who did end up losing her life. So I think this is a massive, important step forward, and I thank you.
Thank you, Senator Eaton. Any other questions to the A17 or the A8? I think we will vote first, Senator Benson, on the A17 and go back to the A8. Is that correct?
Yes, Mr. Chair, I move the A17.
Okay. So if there's no further questions, members, we are going to vote on the A17 amendment to the A8. All in favor of the A17, please say aye.
Aye.
Opposed, nay. Amendment passes to the A8. Senator Benson.
Thank you, Mr. Chair. I move the A8.
Any questions or comments on the A8, members? Okay, we will vote for the A8. All in favor of the A8, say aye.
Aye.
Any opposed, nay. A8 carries. Senator Benson.
Thank you, Mr. Chair. I think we move now to the A9 amendment. And this is updated on your spreadsheet. Mr. Albrecht, can you walk us through the fiscal note? Mr. Chair, I'm going to offer the A9 and then ask for Mr. Albrecht to walk us through the fiscal note that is available to members.
Mr. Albrecht, do you want to speak to the spreadsheet?
Madam Chair, which fiscal note are you referring to? I guess I wasn't expecting that.
I'm sorry, Mr. Albrecht, it was to Senate File 1257.
Is that the fiscal note for the fingerprinting?
I'm sorry, Mr. Albrecht, you broke up a little bit. That was the background studies, the hospital request.
What's new to to the spreadsheet is just the cost of the on-site fingerprinting.
Okay, thank you. Mr. Albrecht, so members, the on-site fingerprinting is requesting that DHS and funding that DHS contract with a vendor to do fingerprinting for facilities identified as having 50 or more outstanding or emergency background checks. As you are well aware, members, we have somewhere around 135,000 emergency background checks that haven't had fingerprints, and this was due to exemptions put in place by executive order and then legislative action. 60 days after the executive order expires, all of those background checks become invalidated. And so, yes, we need to move some language to extend those emergency background checks, but I want to get in front of it and start having the FBI background checks run at facilities with high counts of emergency background checks. And I'm actually, for full disclosure, I'm going to move that this be done with federal money because it is directly COVID related. But when I asked the department to do this work, I did not specify federal money. I was more interested in getting the idea moved out than fighting over federal dollars. And so this will, so that is the cost part of the amendment. The other language was available on Wednesday.
Thank you, Senator Benson. Senator Abler.
Thanks, and I think this is a great idea, and I think absolutely using federal money for this is the correct answer. Senator Benson, can you just comment on the other background study stuff? I think I've kind of lost track. I think that this is going to go in, that's all going in this bill. Can you just maybe summarize the status of all that as well? Is that a fair question to ask now? Because I know we're all interested in trying to make it work with, delays and, all that. So the backlog, et cetera.
Yes.
Senator Benson.
Thank you. The Senator Utke had a bill that extended the emergency background checks to 180 days, I believe it was, after the end of emergency powers. This also contains, and I'm trying to direct members to that, it changes, we don't have to have just one fingerprint vendor in the state of Minnesota. We had one and caused them to not be quite as responsive as we had hoped that they were going to be. But more importantly, this actually started with with MDH licensed facilities such as hospitals, wondering why their licensed medical professionals who had to go through a background study at as part of their obtaining a license in the state, and then have to go through one at DHS as well. So this relieves that second DHS background study for licensed medical professionals who already have to have a background study as part of their licensing. It took a little bit of work to properly separate those without creating a gap in responsibility. Now, again, people who work at facilities that are under DHS licensure can still be background checked by DHS, but if DHS doesn't have any purview, then their medical license background check is sufficient. So that's a very important part of this bill as well.
Thank you.
Senator
Thank you,
Abler,
Mr.
any
Chair.
other questions or?
Oh, that's good for now. When the dust settles, I think we're going to have quite a good background check package with everything. So just wanted to make sure. So thanks.
Yep, thank you. So members, any other questions on the A9? Okay, we will vote on the A9. All in favor of the A9, say aye.
Aye.
Any opposed, nay? E9 passes. Senator Benson.
Thank you, Mr. Chair. That is all of the amendments that I had committed to offering. I know that Senator Abler had considered or has the A4 amendment.
Okay. I
Yeah.
will Senator Abler.
Yeah, Mr. Chair, I'd like to move to A4. And I was hoping that the advocates could have been here, but they're tied up. But I think you'll remember that this whole project has to do with well, you don't know what the project is, about reusing drugs that are still good and setting up a repository. And it's actually kind of working. They've kicked it off. And it would have been fun to kind of hear. This is actually just an amazing story about how just regular students thought of an idea and it made sense and it's law. And now we're actually cleaning up the language a little bit. So this amendment, and so it's just a real testimony that actually citizens can accomplish something here. So this amendment does 4 things. It allows them to accept over-the-counter medications into the inventory. Changes the documentation maintenance requirements from 5 years to 2 years, which is actually consistent with the pharmacy statute 151. It removes some of the specific step-by-step instructions, and they still have to do a lot of procedures overseen by licensed pharmacists, but it's less prescriptive. I'll just do practical ones that are necessary. It also allows them to work with out-of-state repositories and kind of exchange. If we have a lot of something and Wisconsin has a lot of something, then they can do a swap. It has no cost, and I think it's a real success story. And with that, Mr. Chair, I'll stand for questions.
Thank you, Senator Abler. We are on the A4 amendment, members. Any questions or comments? Okay, we are going to vote on the A4 amendment, members. All in favor, say aye.
Aye.
Any opposed, nay? A4 carries.
Thank you, Mr. Chair and members.
Thank you. I would like to go to my amendments next, if that's okay with everybody. So I would like to offer the A3 amendment. And the A3 is an amendment, was in bill form in the past. I think both sides of the aisle have worked on this issue. So I want to give a thanks out to everybody that have worked on this. Senator Klein.
Oh, I didn't mean to interrupt you, Mr. Chair. You can introduce the amendment. I don't want to speak to it before you've spoken to it.
Oh, that's fine. This is the gag clause removal. Pretty straightforward. So Senator Klein.
Yeah, I just want to compliment you again, as always, on introducing very judicious and meaningful legislation and amendments. I strongly support this prohibition on the gag clause for these pharmacies. Just another step towards consumer protections for pharmaceutical prices in our state. So good amendment.
Thank you, Senator Klein. Members, any other questions or comments on the A3 amendment?
And Mr. Chair?
Senator Benson.
I have talked to the PBMs about this, and I didn't get a real clear explanation as to why this is problematic. One of the things that they stated, one of the objections they stated, was that this would confuse consumers, and I don't consider that a compelling reason to not adopt this language, and so I will follow the committee's lead on this, but I do not object to this language.
Thank you, Senator Benson. Senator Abler.
Well, thanks. In this world of shorthand and texting, I think PBM could be another shorthand for a problem. And that's not meant to be that funny. Yeah. So, there's benefits, but holy cow, they're running the whole place. You have a bill, Senator Draheim. I hope that actually passes. At the end of the day, it's the job of, I'm at my clinic today, so I'm in a clinic mode. It's our job to serve the people the best we can. Dr. Klein knows that. And what's good for the people is good. And if you do enough good for the people, you'll make plenty of money if you're a PBM or an insurance company or a clinic. And so I would, for heaven's sakes, hope that we can adopt this and turn it into law. If there's no transparency, you have almost nothing. So I guess I'm supporting the amendment. So thank you.
Thank you, Senator Abler. Senator Wickland.
Thank you, Mr. Chair. I just wanted to add, I'm supportive of this, and I think that we had discussion about your bill earlier, and I was supportive of other greater clauses that we could add to language. But if we're able to move this particular prohibition forward, I think that's a positive step for consumers. Thank you.
Thank you, Senator Wickland. Any other comments or questions on the A3? If not, we are going to vote on the A3 amendment. All in favor, say aye.
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 Any opposed, nay?
Yay.
Amendment passes. Thank you. Members, I would like to do one more amendment that I have, and then we can get on to the others. So I have the A22 amendment, and this was part of the Senate File 917 that I worked on, trying to save the smaller independent pharmacies. And this was the last section of that bill. So the A22, does everybody have the A22? So I'm assuming everybody's good. So this here has to do with the billing and the clawbacks, if you will, that no PBM will retroactively deny or reduce a claim after 30 days unless it was submitted incorrectly. So if it was fraudulently submitted, or if they were already billed for it, double billing, if there was an error in accounting. So pretty straightforward. I really wish we could have moved the rest of this bill in this one, but I know there's some things we're waiting on a fiscal note. But these pharmacies, these local, underserved areas, rural, inner city, they're closing every day, and like we heard in testimony on the bill, we've had more pharmacies close in Minnesota than any other state in the last decade. So this is one thing we're trying to do to save them. So I hope you'll support the A22. Any questions?
Mr. Chair, and 917 had a lot of issues that needed to be worked out. For example, wholesale acquisition costs, just some big definitions that a lot of those changes came out of Rutledge, which is not a very mature Supreme Court decision. We haven't seen it work its way through the legislative process. So I was concerned about the amount of work that needed to be done. I'd like to hear from the PBMs on this. I have heard that there are retroactive adjustments that go back 6 months, and just the practicality of having closed up your books or even your fiscal year and then having to retroactively adjust. And so I think it's important that we hear from the PBMs. This seems like a fairness issue, but I think we do have a responsibility to hear from the people who have to do this about why it might be problematic to implement or why it doesn't work. But to me, it seems reasonable.
Thank you, Senator Benson. Any questions or comments to the A22 members? Senator Wickland.
Thank you, Mr. Chair. I was just wondering, is there any ability to hear that feedback today? Is that what Senator Benson was asking? I don't know if there is anybody available to comment on this.
Thank you, Senator Wickland. Senator Benson.
And Mr. Chair, I believe there is somebody who represents the PBMs. I thought she was on. I hope she would raise her hand. And okay, very good. She's on camera. So, Mr. Chair, if we could go to Ms. Mack.
Yes, please state your name for the record.
Chair Dreheim, Senator Benson, Michelle Mack from PCMA, which is the Pharmaceutical Care Management Association. We're the national association that represents the pharmacy benefit managers. Their trade association is based in DC. I'm actually live in Minnesota myself. We are opposed to this, and I just wanted to say the kind of reasoning why we are opposed to this. When you're talking the retroactive adjustments, we're hearing this a lot from the pharmacists across the country, and this really deals with an issue that we call DIR, which is direct and indirect remuneration, which is a federal issue that CMS does, and it is actually CMS does this in the Medicare Part D program, and it's more of a way for the pharmacies to try to get them to get insulin, get people adherent, and it's a goal for them to do that. Like relative to this issue, this will not solve that DIR problem. That's something that they need to work on at the federal level. The second item I wanted to address was this was enacted back in 2019, and we're still waiting for the rules from the Department of Commerce relative to the original language. So there is that still out there as well. And the final issue that I wanted to address is we do have some language that we would suggest. And that language is essentially just saying, unless otherwise stated in a mutually agreed upon contract. And we would just add that to essentially line 1.6 of the 8th 22 amendment. So I just wanted to add that. I guess the final thing is the language does take out technical billing errors, and technical billing errors are, there's something that we find on the back end. And we, unfortunately, errors happen, and we need to go back and fix those items. Some of that is addressed in the audit language, which is found, in section 62W.09. But those are the items that I did want to address. Thank you.
Thank you, Ms. Mack. And I think for the record, I think we heard in testimony on the 917 file, the retroactive can go back 2 years, folks. 2 years. So anybody that's running a business, hard to plan. And we're the worst state in the last decade of losing pharmacists. And we're losing them every day. And underserved areas, that's inner city and rural. I don't think this is a bad amendment. If 30 days isn't right, about 60 days. But 2 years is just too far. So, Senator Abler.
Well, thanks. And I think I appreciate your work on this. And I just don't know why it's always so combative with the PBMs and the providers. It's supposed to be a partnership. And, I don't know of any, it's curious, there's a term called these paper billionaires, which none of the people in greater Minnesota are anything approaching that. But I just would also like to comment. So you get to have it, they get to have it both ways. There's a billing limitation. If you haven't sent a bill to some provider to a carrier within 90 days in some cases, it used to be 180, but it's getting shorter and shorter. If you don't bill it in time, you don't get paid. Even if you weren't sure who it was, and maybe you can appeal it, maybe not. But now they can go back 2 years and take the money that you had to get to them on time. So Senator Draham, I'm with you to try to address this. And if you want to accept their language or not, that's up to you. But I just think that I'm so frustrated. I'm trying to be polite to all the players here, but until it just seems like when we talk to these greater Minnesota providers in particular and the rest, that until there's an amendment like this coming forward, there's no dialogue with your national association or anybody. And it's always, federal this or federal that. And, we'd love to help, but, we're going to keep the money. So anyway, so that's my thought. So I'm trying to be useful here, but then we should extend the time for billing if we're going to do that and it should be the same number, whatever that number is. Thanks.
Thank you, Senator Abler. Any other questions or comments on the 822 amendment?
Mr. Chair,
Senator Benson.
did have a question, perhaps Council, Ms. Kavanaugh could help. Why was technical billing error removed? Because I think if there is a technical billing error, it should be, outside that that's not a fairness issue or a transparency issue. That was a mistake. And so I don't recall, I don't understand why that would not be reinstated language.
Senator Benson, that was, you might want to ask Senator Draheim, that was a request from the advocates, and I believe they thought it was just too broad of a term, and that it was being used, you know, that it would cover way too many things. So I believe that that was their concern, is that, you know, anything could be considered a technical billing error, is I believe what they, how they felt about it. But again, that was a request.
That is absolutely what I recall, Senator Benson, was that the technical billing error was being abused, and that's why they asked for it to be omitted or removed from the chapter.
Senator Draheim, is it, is the original claim was submitted fraudulently, and then the second item, the original claim was incorrect because the pharmacy already paid? Are those substitutes for the technical billing error?
Yeah, I think, I believe it is trying to correct the most common happenings of a reason why the pharmacy would have to pay the PBMs back.
Mr. Chair, I guess I would be more comfortable if we could reinstate the stricken language on 14 and 15 and work on that. I can accept this language because I think there is a fairness issue here and a business operations issue. I am concerned about taking out technical billing error, because what if there was just an interoperability issue that's not covered in the previous 2 points? So I'm not trying to weaken your amendment, Mr. Chair. I understand the frustration of these smaller pharmacies who spend so many hours on paperwork and get money taken back from them 18 months after they think a claim is settled. So I wonder if you would be open to that adjustment.
You know, what I heard, I talked to probably a dozen pharmacists on this bill, and everybody complained about the technical billing and how it was being abused. So I am willing to work on the language, but I think we need to put some rails around it. I think technical billing is too broad, and it has been abused. So you have these billion-dollar companies abusing these mom and pop pharmacists that are barely hanging on, and they don't have a room full of accountants and actuaries. So I'm willing to work on it. I would rather not put in the original language, but I would willing to work on some kind of compromise on that.
Mr. Chair, I think Senator Wickland had her hand up. I'm just trying to think through this.
Yep. Thank you, Senator Benson. Senator Wickland.
Thank you, Mr. Chair. Yeah, I was going to say I would like to be able to support this amendment, as I do think that the pharmacies, local pharmacies, are in a position of kind of an imbalance in power with the PBMs, and I don't think that the current status of retroactively looking at statements and going back to them to get corrections by the PBMs, I don't think it's really reasonable the way it currently works. I think it does place too much burden on the local pharmacy and inordinate negative impact on them. I just want to make sure that whatever the language we use does what we say and is in alignment with anything that is planned in the current iteration of the PBM licensing rules, which haven't haven't come out yet, as far as I know. So, but I do support the concept, and I hope we can find a way to write the language. Thanks.
Thank you, Senator Wickland. And if I could go back to Ms. Kavanaugh and ask if there's anything in language that defines what a technical billing error is.
Senator Draham, no, not really. And, you know, maybe that's one approach you could take if you're working on that, is to be a little bit more specific of what a technical billing error is, or maybe, you know, I mean, you are reducing the number of days, so you can't go 2 years and then say, oh, geez, we're going to adjust this because of a technical billing error. So maybe there is some there where, you know, if there is a technical billing error, you have to, you know, a PBM would specifically have to get back by, you know, 3 business days or 10 business or something like that. But
Thank you. Senator Benson.
Thank you. Mr. Chair, so the technical billing error is under the pharmacy audit provision of 62W. So it would have to be a technical billing error found during an audit. And because I don't understand that audit process well enough, I don't know if it could be a PBM just claiming, oh, this was technical. I think it would have to be part of a process. But I like Ms. Kavanaugh's idea of better defining a technical billing error. So I would appreciate it if we could reinstate that stricken language, and then because it's nested in the audit, it's not just a get out of jail free card that's somewhere else in the bill, it's nested in the audit, but then work on a definition of what a technical billing error would be. I don't want to leave us uncovered, but if the committee doesn't want to accept that, I get it, but I feel like there's a little comfort under the audit provision because it has to be part of an audit process. They can't just send a letter and say this was a technical billing error. But again, I don't understand, I'm sorry. I haven't had specific examples of technical billing errors being used as an excuse. And so I'm having a hard time wrapping my head around what some of those excuses might have been.
Thank you, Senator Benson. Ms. Mack, would you like to comment on Senator Benson's question about technical billing errors? Could you give us some examples?
Thank you, Chair. I really don't have examples right now that I could provide with you, but I'm more than happy to provide them at a later date and also work with you on this language.
Ms. Mack, do you know how many technical errors are given out? You know, do you guys track how many are used back to the pharmacies? From what I heard from the pharmacists, it was quite a bunch. So do you track the clawbacks and what type, you know, so we're looking at, you know, fraudulent claims were looked at for some reason if they were already paid, and then this technical issue. Do you track those individually?
And, you know, I represent the association, so I'm not quite sure how each company tracks and how they do different things like that. I do know that sometimes the word clawback is used, and the definition of clawback is different for different parties. And again, you know, there's the federal DIR, and, you know, there's those things as well. So unfortunately, I'm sorry, I do not have that information at the moment.
Thank you, Ms. Mack. Senator Benson, I guess if your wishes are to reinstate the technical billing errors, I think it pretty much makes this amendment worthless. And I would offer to remove it if you want. It's your bill, and I don't want to put anything in there that you're not comfortable with. But I do believe that all the testimony and all the pharmacists we talked to, that was the number one issue, was the technical billing errors, because it's been overly abused. And I'm willing to work on a definition of it and put it back in at a later date. But you know, right now, I would just withdraw the amendment and continue to work on it.
Senator Draheim, I do think that the 2-year window and the broad exemptions are problematic, to say the least. And so I'm just trying to figure out how to keep people at the table to stay engaged. If we need to move the number to 60 days, if we need a clear definition of a technical billing error. So I don't mind the intent of the language. I just don't want to move so far that people think this is done and then they step back. So I'm trying to find a way to craft this so that people stay engaged and work on the technical billing error and the number of days. Those are the two things I feel, those are the two things I think need the most work. So how are we going to do this, Senator Draheim? Senator Abler's got his hand up.
I see that. Thank you.
Well, thanks, Madam Chair. I appreciate thanks, Mr. Sorry. I have to wait for you to call on me. So, Mr. Chair, on behalf of the other chair, I appreciate where you're at, Senator Benson, on this. I do want to remind you just where we are in the process. It's in a bill that you're going to be, this part in particular, you're going to be in direct control of. So I think Senator Draheim is going to realize at the end, if he doesn't make this work to the satisfaction of you and some others, that it's going to be a dead end trip. But I also think that leaving that in there or leaving it out the way it's out creates more discussions. And I think that everybody is clear on your perspective. I think they're clear on my perspective and some of their members. And so I think if you don't mind leaving it just the way it is and letting Senator Draheim do his due diligence with well-intended PBM people and the pharmacists, I think at the end it could be a pretty good product. That's just my thought. Thank you.
Thank you, Senator Abler. Senator Benson, would you like me to withdraw this and let you think on the 822 and I can bring it up later?
Senator Draheim and members of this committee, the members of this committee are the people who are experts on this. And I don't want to withdraw it and then have a floor fight or do it in finance. I think this work needs to be done. So I would like some shape of this language to end up going into conference committee. I want to make sure we have people at the table talking about if 30 days is reasonable and what a technical billing error is. And so at this point, I would rather move some shape of this language, but I don't want people to walk away and think they're done. And Senator Draheim, you don't walk away and you don't think you're done. But I'm afraid if we don't, I just don't know what a technical billing error is. So I'm not going to ask you to withdraw. I just need I need some commitment. I need a definition of a technical billing error. And I guess when it comes down to it, I can always drop this at some point if I don't get a definition of a technical billing error. So I'm not thrilled, but I would rather take a not thrilled than not have you move this idea forward. So I'll take a not thrilled vote on your amendment, Senator Draheim.
I appreciate that, Senator Benson. And I didn't mean to put you on the spot on that. I'm just trying to solve a problem. So members, any other questions or comments to the A22? And of course, I'm willing to work on any language on any subject with anybody. So thank you. We are going to vote on the A22. All in favor of the A22, say aye.
Aye.
Any opposed, nay? Amendment passes.
Mr.
Mr. Chair?
Yes.
Mr. Chair, I did abstain on the A22 because I do
Okay.
believe there's some work that needs to be done.
Mr.
Noted.
Chair?
Thank you. Yeah, Senator Abler.
I think you failed to request the not thrilled category of voters. So I just wanted to point that out. Thank you.
Thank you, Senator Abler. We will go to Senator Nelson.
Thank you, Mr. Chair. I have the A24 amendment, and I will just briefly offer thanks to the department that provided some technical assistance to Senate File 1321, which has to do with children's mental health intensive in-home care design. And I am thankful for this very small amendment, which does not do everything in Senate File 1321. It actually does need some more work. And we just appreciate the good discussion and thoughtful collaboration around the children's intensive mental health design to provide treatment for children with their families. And we do look forward to bringing back this full bill next year for consideration. We had a great hearing earlier in, I believe it was Senator Abler's committee. But positively, we are hoping that yet this year, working with the department and their technical assistance, that we can bring some modest flexibility in the intensive treatment in foster care. As you know, it's a wonderful service. It's been underutilized, and we know that the needs that children have for mental health care have been growing, but particularly have been growing through this pandemic crisis. So accommodating family and child need around the scheduling of 6 hours of treatment. This bill simply makes some very modest changes, technical assistance from the department, which would allow that 6 hours of treatment to occur in the home over more than 3 days a week, but keeping the amount of hours the same. It's to better help children and their families and improve the many schedules that they have. The one thing I would like to do, though, Mr. Chair, is we believe, as the technical assistance from the department indicated, since this is just providing flexibility in the hours, not providing more hours, just providing flexibility in when those hours occur. We don't believe there's a fiscal note, and that's what I have been told as well. But yeah, I think it would be helpful for me to know, and probably for Chair Benson as well, if we have someone from DHS who can testify to that fact, that this very small implementation of the total 6 hours a week of service does not increase cost.
Thank you, Senator Nelson. And I just want to make sure all the members have a copy of the 824 amendment before we go to DHS. Everybody good? I assume so. Thank you. I don't know who's on for DHS that could talk to this, but if you could, please state your name for the record.
Yes, thank you, Mr. Chair. For the record, Matt Burdick with the Department of Human Services. And I know our teams have been doing quite a bit of work with Senator Nelson and the advocates regarding this language. And I apologize for any confusion. We are still assessing if there are any cost implications to Section 1 of this bill. Part of the reason being that if we're allowing more flexibility, we might see more billable units. And so we need to look at some of the underlying claims data to understand how that might occur. I would also say that Section 2 that speaks to the weekly rate is something that we have talked about having some concerns about and want to continue dialogue on. But overall, we agree this is a really good idea, and we want to be helpful in making that work.
Thank you, Mr. Chair.
Senator Nelson.
Senator
Yes,
Nelson?
I thank you, Mr. Chair. And I do want to make sure that Mr. Burdick is looking at the amendment language. So there's only like there's like no changes except on line 2.1, not limiting it to 3 days per week, but still equaling 6 hours of treatment per week. So it was not the full bill, Mr. Burdick. It is just the little technical assistance that your staff had offered. And the only other change is in line 2.21. The commissioner shall establish a single daily, crossed out, weekly per client encounter for these intensive services and foster care. But there's no increase in rate or the numbers of hours. So this is like a very, very small piece to try to provide just a little bit more flexibility as families and their children are working through these difficult times. So I did want to make sure, Mr. Burdick, that you knew that that was all the amendment does, the A24.
Mr. Burdick.
Thank you, Mr. Chair and Senator Nelson. Yes, we are looking at the same language. The second point I referenced is the change in the rate structure that I think we want to continue talking with you about. And then to your original point, with that flexibility, we want to make sure that we are really looking closely at how does that change any billing experience. And so, again, don't have any issues with the overall policy and concept, but we were just scrambling to look at this morning, and so we're still trying to assess if there are any fiscal costs. And I want to be clear that we have not made a determination that there are any fiscal implications yet.
Thank you, Mr. Burdick. Senator Benson.
Thank you, Mr. Chair. I remember hearing this language, Senator Nelson, and it seems like a good idea. And if you move from a daily rate, you move to a weekly rate, that all makes sense. I'd like to hear from the committee if there are any policy concerns, because I don't think there are any policy concerns. And then it just gets down to cost. So if I could ask Mr. Burdick, how long do you think, and I'm not talking about today, do you think by next week sometime you could have an assessment of cost?
Burdick.
Thank you, Mr. Chair and Senator Benson. Absolutely. We are actively working on it. I've actually got a little chat going on my other screen with people busy thinking this through right now. So this is a high priority for us, and we'll easily be able to meet that deadline.
Thank you. Senator Benson.
Thank you. Mr. Chair, I'd like members of the committee to raise any policy concerns or support. I would appreciate both of those. And given that we don't know the fiscal implication, I'd rather wait for finance. If the committee's okay with the policy, I'd rather wait for finance and not try to adjust things in committee here without having some sense of the cost. It's probably a small cost, but every time I think something's going to be a small cost in DHS, I end up with 2 commas and 6 zeros. And so I would rather wait.
Senator
for
Benson, I
finance.
think your volume went out.
Mr. Chair, we've been having some volume issues here in 1200. So I'd like
I
to.
still can't hear you. I don't know. Anybody else?
I can hear her fine.
We can hear
I
fine.
heard fine as well.
Okay. Must be my fiber here.
Okay.
Sorry, Senator Benson.
So, Mr. Chair, I'm not seeing any hands raised to object. I think this is good policy. I'd prefer if Senator Nelson withdrew and then we worked on this for finance, given that the committee supports the policy in general. I just need to know the number for my spreadsheet.
Senator Wickland.
Just a comment. I mean, it seems like from what Senator Nelson has said that this is meant to be helpful to families who are utilizing this service. And if so, and it doesn't cause unintended consequences, it seems like the policy would make sense. So, I mean, I'm not hearing anyone saying that they don't think it's helpful for the patient and the family. And that would be kind of my concern, is if it had a negative impact on them. So thank you.
Thank you, Senator Wickland. Senator Nelson.
Yes, thank you, Mr. Chair and Senator Benson for the conversation. And I do want to just note, it does not increase the number of hours, nor does it increase the rate. So in my mind, the math is very simple. If you pay for 6 hours a week and you pay for 2 hours, 3 days a week, or 1 hour, 5 days a week and 1 hour another day. I mean, the point is it's 6 hours and it's a weekly rate over a daily rate. But I do understand the challenges of trying to get a spreadsheet to balance, and you don't want any unnecessary surprises going forward. But I do believe, Senator Benson, that you did get good confirmation from the department that they will have some dollars available for this. And as tax chair, I don't sit on the finance committee anymore, but if I could make sure that this amendment is offered in the finance committee, we'll make sure that, Senator Benson, that you have everything you need for that. So thank you so much. And with that, I will withdraw the A24, and I greatly appreciate the committee's time and the chair's time and interest in moving this forward. Thank you.
Thank you.
Thank you.
And
Senator Benson.
thank you, Senator Nelson. I'd just like to make a request of our nonpartisan staff to have the A24 then drafted for finance and work on a fiscal note so that it could be added to the spreadsheet after I see what the dollar amount might be. Because I do think it's a policy that makes sense, but I know that sometimes, even with an individual encounter, there are travel costs incurred. There might be other billable ancillary costs associated with changing the number of hours. And so I just want to make sure I know what I'm getting into. So thank you, Senator Nelson, for this good work.
Thank you.
Thank you, Senator Benson. Members, any other amendments to Senate File 2360? Senator Klein.
Thank you, Mr. Chair, and I offer the A10.
Senator Klein offers the A10 amendment, members. And I believe that was in our list. We should have that. Do the A10, Senator Klein.
Well, thank you, Mr. Chair, and thank you, Senator Benson, for the omnibus bill. And I want to alert the committee in advance that I plan to withdraw this amendment because I think it's important that we heard it as a committee. It didn't receive a hearing this year, but it's a meritorious idea. I think it is nonpartisan and it will help Minnesotans at a very low cost. And I would hate to put it to a vote and have it voted down for the sake of preserving the bottom line of this bill, because I think there's hope for this concept yet this session. So I just wanted to present it here in committee for the interest of the members. This comes from my bill this session, Senate File 786, which establishes recuperative care for people experiencing homelessness as they are discharged from the hospital. You know, in my own experience, and I'm sure for many of you, it's not uncommon for doctors to discharge a patient from the hospital when we don't know if they have a place to go when they leave. They're literally carrying around everything that they own, including their medications and wound care supplies, often not have access to a bathroom or a shower, and they don't even know where their next meal will come from. It's costly and it's an inhumane way to have revolving hospital door care for people experiencing homelessness. This bill 786 didn't receive a hearing this year, but it's the third year it has been proposed and it's been heard in the committee the last 2 years. Recuperative care services are a national and well-proven model to provide time-limited wraparound services in a shelter for a person where they can receive nursing care, wound care, mental health care, and support to find housing and more in a limited amount of time, usually 30 or so days, to not only heal from their illnesses, but to reach stability, stopping that revolving door. The bill has a price tag of $200,000, and that would go to DHS to develop recuperative care as a health home. Health home models are wraparound services for hard-to-serve Medicaid populations like people experiencing homelessness. DHS will then work with stakeholders and actuaries to determine costs, rates, eligibility, and services that would be included in that service. And it would draw down an additional $200,000 from the ACA that exists for the purposes of planning a health home. This bill has had bipartisan authors in the past, as it has this year, and would go not just to one health system in this state, but to multiple health providers throughout every corner of this state. It's an urgent priority for the committee, and I'm interested in the feedback on the policy, on the funding, and then when we're done with the discussion, Mr. Chair, I will withdraw.
Thank you, Senator Klein. Senator Benson.
Thank you, Mr. Chair, and I believe HCMC has done some pretty key work on this. And so, Senator Klein, I do have a question on line 11 of your amendment. The development of a recuperative health home model. Do you know where the development of that model is in its maturation and implementation?
Senator Klein.
That is a good question. I wonder if there are actually testifiers available in the audience who could help me out with that. If there are, I wonder if they could raise their hand. If not, Madam Chair, I will get that information to you prior to your next committee visit.
Is there anybody? I don't see anybody raising their hands.
Well, let's give them a little bit of time. One of the things that has challenged me about this in the past is how it intersects with MA and what sort of build on costs beyond just requesting the grant. Now there's MA housing supports available, so I'd be interested to see how that might work with this as well. And frankly, we have a lot of federal grants at the Department of Health already. I wonder if there isn't some grant that might mesh with this already. And instead of, and Senator Klein and I have talked a lot about doing duplicative work. So some of those kinds of answers might help mature this idea. So where is the development of the health home model for recuperative health home model? How does MA housing intersect with this kind of proposal? Because that would have a funding component. And then is there existing federal money, and particularly now, Senator Klein, is there housing money or healthcare recovery money that might make this more viable? And I simply haven't had time to do that level of engagement on this language, but those answers would be helpful.
Senator Klein, before you answer Senator Benson, I was going to let you know today, the White House put out another $3.5 billion for homelessness, and being the housing chair, I get updates all the time on all the money that's coming through. I like the concept. I think we should look at if we can get some of that federal money coming in from the new batch that was just announced today. So whatever that's worth. Senator Klein.
Thank you, Mr. Chair, and thank you, Senator Benson. And again, I think it sounds like everyone here agrees that the concept is meritorious, the need is real. And Madam Chair, you've asked some very practical questions about the how this interacts with other programs, and specifically how the funding might work and where the planning is at in this stage of development. You certainly deserve those answers from me and from the advocates before you would move forward on this. I continue to hope that it can happen this session. And with the addition of federal funding, as Chair Draheim mentions, there may be a real window here. So with that, out of respect for your concerns, I am going to withdraw this, the A10, and hope to stay in contact and work with you, Madam Chair.
Thank you, Senator Klein. Senator Benson, any comments?
Oh, I appreciate it. And frankly, given the amount of federal money that's around, I think we're going to have to restrain ourselves from out there sort of ideas. So a well-developed idea would probably have good bipartisan support, Senator Klein and Senator Draheim.
Thank you, Senator Benson. Members, any other amendments to Senate File 2360? Senator Eaton.
Thank you, Mr. Chair. I would like to offer the A6 amendment.
A6 amendment. Members, we should have that in our packets to the A6. Senator Eaton.
Thank you. The A6 amendment calls for a grant through the Department of Minnesota Department of Health, $275,000 from the general fund. And this would be for anti-racism research. They just recently established the Center for Anti-Racial Research for Health Equity at the university. And this would provide funding to work on reducing the disparities in maternal and infant health. In Minnesota, and I find this actually embarrassing, Black women are 2 to 3 times more likely to die of pregnancy or childbirth related causes than their white counterparts, and Native American women are 4 times more likely. And the maternal deaths, over half of them occur in greater Minnesota, and over 60% are preventable. And regardless, in the studies, they've looked at the education, the income, the socioeconomic status, and so on, and it makes no difference. The only difference is the race. So this gap that persists is, well, it's unacceptable. So the disparities can't be explained by, like I said, education or general health or anything else. So what the amendment does is the first step toward making sure hospitals and that provide obstetric care and birth centers are providing continuing education on implicit bias and racism training. So I think this is an important first step to, I mean, it's bad enough that we're one of the worst in the nation on educational disparities, but the fact that we're also, there's this big a difference between the survival from childbirth for someone just because of their race is unacceptable. So I ask for your support.
Thank you, Senator Eaton. Members, any questions? Senator Benson, any comments?
Thank you, Mr. Chair. So the Minnesota Department of Health does have a $5 million health equity grant that has been in place now, I believe, for 20 years. I believe this is the 20th year. And so, Senator Eaton, I think having them tag some of that money and pull it over to do this work is completely within their purview. I know the University of Minnesota School of Public Health just got a significant, as you mentioned, Blue Cross Blue Shield grant, but I think given that there's $5 million in health equity money and it is the 20th year, I think your idea here could be elevated to the level of taking some funds from that grant, because their goals are very much in line with the idea of this language. And so, Mr. Chair, actually, I'm just pulling it up. The EDI provides, EHDI provides $5.142 million annually to organizations and tribes to cover many health areas: breast cancer, cervical screening, diabetes, stroke, heart disease, HIV/AIDS, immunizations, infant mortality, teen pregnancy, unintentional injury and violence. I think, Senator Eaton, I think your agenda here, your mission fits well with their goals of increased capacity, enhanced skills. So I think that would be a good place for this money. Instead of taking new general fund money, help them refocus with your input, Senator Eaton. So I'm going to oppose the spend, but not the idea. So if you could propose this to the department as a way to use their existing health equity money, I think that would be a good approach.
Senator Eaton.
Thank you. Well, I understand your perspective, Senator Benson, but I think that it's important that we have a evidence-based model curriculum that deals with the implicit bias that we're dealing with, that is actually causing women that aren't Caucasian to die at higher rates, and the infant mortality is comparable. So I see this as a crisis situation that needs an evidence-based curriculum that is put into the system. And I think the directive is important. So I would still encourage support.
Senator Nelson.
Excuse me. Thank you, Mr. Chair. I appreciate this discussion and really thank Senator Eaton for bringing this forward. I think we all should be concerned about maternal health and death in childbirth. That's something that we should not be seeing in our country. And those significantly higher rates for women of color are very concerning. But I would like to direct staff to prepare an amendment to the amendment, which would direct Senator Eaton's good idea to be funded through those existing funds in the equity grants. I did hear that was exactly what Senator Eaton was hoping, and I do too. And so I'm wondering if this is an amendment that staff could prepare to the Senator Eaton's amendment about where the money would come from.
Senator Nelson, would you like to go to Ms. Kavanaugh then?
Yes. Thank you, Mr. Chair. Ms. Kavanaugh, are you able to give such an oral amendment, or do we need to recess until you can give a better amendment? It seems like a very simple thing, but I don't know if you can immediately pull the language together.
Mr. Chair and Senator Nelson, I would need a few minutes because if I understand it, what you're saying is you would direct the Commissioner of Health to use $275,000 of the appropriation to the Commissioner for the health equity grants to be used for to develop this curriculum.
Correct.
Yeah, I need a few minutes to do that.
Thank you, Ms. Kavanaugh. Oh, Mr. Chair, thank you. My intention is that it be part of the $5 million grant that is already in place. That is the surest way to make sure that we get action on this important issue.
Well, Ms. Kavanaugh is drafting this amendment. I will, if it's right with everybody, I'll continue on with the hands up, and then we'll come back when Ms. Kavanaugh is ready. So Senator Wickland.
Thank you, Mr. Chair. I did see Senator Eaton had her hand up about, I don't know if she wants to respond to this particular request or idea that Senator Nelson has brought forward. It's her amendment. I'd prefer to hear.
Okay, Senator Eaton, would you like to go first?
Mr. Chair, I don't know that it matters. What I wanted to bring up was the fact that the current funding from the Department of Health covers infant mortality, but it does not specify maternal mortality. So I'm not sure that that fund could be used for that at this time.
Okay. Senator Wickland.
Thank you, Mr. Chair. I will just speak to, I'm assuming that Ms. Kavanaugh is working on an amendment, but I will just speak to the amendment as it is right now. I support it. I think we should be allocating funding for this outside of the current funding source. I mean, it sounds like there's a question whether it could be used for this purpose anyway. But then I just think that we need to be taking action now, and this is a tangible way to direct an institution that is focused on how to address maternal health to create a model curriculum that would be helpful to training providers. And it would coordinate well with other language that is currently moving in the House, which has to do with dignity in pregnancy and childbirth. And it requires that health providers who work in hospital settings where obstetrics units, birth centers, that they take anti-racism training and training on implicit bias. And I believe that having an entity like the University of Minnesota tasked with developing a model curriculum will fit well with the work that is intended to go on by this important language that's in the other body right now, having to do with improving maternal health outcomes. So I support the amendment as it is right now. Thank you.
Thank you, Senator Wickland. Senator Benson.
Thank you, Mr. Chair. I'm trying to find out if this health equity grant, I'm trying to find out what section of law it's drafted to so that I could go look at the source document for this particular grant. Ms. Kavanaugh is working, so I'm not going to ask her to hop over to it, but members, there's an entire section of grants that were put in place that are very flexible, and the department can choose what they do with that money. And so just because to Senator Eaton's point, the department doesn't do it now, it doesn't mean it can't be done. So they have eliminating health disparities grants that I'm just trying to find some examples. I listed some of those earlier. The grantees use a variety of strategies, including research-based or evidence-based strategies. If you wanted to, Senator Eaton, if the language is so restrictive for the Eliminating Health Disparities Initiative, if you wanted to move from infant mortality to include maternal health, but they already have research-based or evidence-based strategies as one of their key criteria. And they are looking at root causes and conditions for health, organizational and institutional change. Level 2 change addresses a health area by changing policies or systems at clinic, school, hospital, or other institutions. So I don't see anything restrictive in the EHDI grant pool that wouldn't allow them to do this. They already have the power to do this, so maybe what they need is your engagement and your direction, and not another $275,000 out of the general fund.
Senator Eaton, would you like to comment on those comments?
Sure. Well, I guess it seems to me like the bottom line assumption is that the money that they have is sufficient, which it is not. There's a lot of issues around health and mental health and substance use disorder and so on that are active in the communities of color and the indigenous population. And this $5 million doesn't go very far. I would like to not take away from the work with breast cancer or whatever and focus on this. I mean, I don't want to take away from another program. I think it's important that we focus on why is it that in Minnesota, if you're a Native American woman and you're pregnant or giving birth, that you're 4 times more likely to die. And why is it that over half of that is in greater Minnesota and 60% of it's preventable? I mean, I just see that we have a situation here that needs to be addressed and at the expense of all the other issues that they're trying to address through the Department of Health. I don't know that I want to decide that they have to cut one of those programs. They have way too much to do with their existing money right now.
Senator Eaton, I could ask you a quick question before we go to Senator Nelson. Have you looked at other states? Is any other state doing this?
No, I haven't looked at any other states. This is actually Patricia Torres Rey's bill, and I strongly support it. And as I'm sure you can tell, I feel very strongly about it. But so I haven't done a lot of research on it, but I do know, having worked with a lot of different areas, like I said, substance use disorder and cancer and so on, that the Department of Health is overwhelmed with what they're trying to get accomplished with that money right now. And I would prefer not to take from another program for this, but I think this is equally important and I would rather fund it. Thank you.
Thank you. Senator Nelson.
Thank you, Mr. Chair and Senator Eaton. Just want to make sure my video was, or my audio was on. Thank you for the good discussion. But I tend to think doing what you have written in the A6 amendment here, Senator Eaton, it's kind of like specifying exactly how some of those funds should be used out of that $5 million equity disparity funding that already exists. And before I continue, do we have, could Mr. Oswald maybe just look up, if he could find it, that the particular language that is around that $5 million? Because I would think that there are a lot of guardrails in there as well, requiring reports, requiring a lot of things that we would really want to know, particularly as we're talking about this area. So could if it's not too difficult, could Mr. Oswald find that reference for us and share just briefly about that?
Thank you. Mr. Chair, this is Ms. Kavanagh's area, and I believe she's working on language.
Okay.
Madam Chair, I do have it is section 145.928, and I don't want to read the whole statute to you, but it's quite prescriptive as to what qualifies for this funding. It has, I can't read it all, but yeah, I've read it.
Senator Nelson.
Yes, I do have it up here. And I would just say it is about eliminating health disparities in infant mortality rates and adult and child immunization rates for American Indians, populations of color, have measurable outcomes, establish a program to close the gap. I could go on and continue to read too: measurable outcomes, statewide assessment, technical assistance, state community partnership plan. Certainly, this is a broader and more resources than what we see in Senator Eaton's amendment alone. And so I do renew my amendment to her amendment that it would be that Senator Eaton's important direction would be included in 145.928. So if Ms. Kavanaugh, or Mr. Chair, I'll turn it over to you if we're ready for that amendment to the amendment.
Ms. Kavanaugh.
Mr. Chair and Senator Nelson, I think this would be, this would be the amendment to the A6. And on line 1 point, let's see, how do we do this? Let's delete lines 1.4 and 1.5. And on 1.6, delete health. And then insert of the appropriation in fiscal year 2022 to the Commissioner of Health for health disparities grants under section 145.928, $275,000 shall be allocated. And then it would be then continue on 1.6 with the original language for a grant to the University of Minnesota. And the original language then would stay in. And then on 1.15, instead of appropriation, change appropriation, delete appropriation, and insert allocation.
Mr. Chair.
Senator Nelson.
Thank you, Mr. Chair. Ms. Kavanaugh, you have masterfully taken what my intention was to further elaborate on and enhance Senator Eaton's idea. And the language that you have read is my intention with the amendment to the A6. So I'd like to renew that motion, Mr. Chair, if it's time to do so.
So members, we have the oral amendment to the A6 before us. To the oral amendment, Senator Eaton or Senator Wicklet?
Mr. Chair,
Yes.
I have a comment on or a question about the impact of the oral amendment. I was wondering if the Department of Health could please comment, not whether they support it or don't support it, but just what would the impact be of changing the language to include the specific source for funding? I would appreciate it. Thank you.
Thank you, Senator Wickland. Do we have anybody from the department that would like to comment on this oral amendment?
Mr. Chair, members of the committee, this is Lisa Timian. I am Legislative Director at the Department of Health. Just, generally comment that department really, we don't absorb costs. We can accomplish some things within current scope of duties. They don't have a tremendous amount of staff time. But it's challenging to actually absorb the costs. I will say too, we do know that in Minnesota, we continue to struggle with health inequity and disparities. And we do view these EHDI as a very important investment that the state has made in eliminating these. It's been something we've learned a lot about in the past year dealing with COVID, and particularly how it's disproportionately affected communities of color and BIPOC communities across the state. So I think we just want to have some further discussions to just make sure that we're not shortchanging any of our other programs that are happening. But happy to continue discussions with the committee on this.
Thank you. Senator Eaton.
I was going to ask the same question.
Oh, okay. So Senator Nelson.
Oh, I didn't have any more comments. I see my hand is still up. Just a note, passing note, Mr. Chair, passing note. There is great competition for funds in the general fund as well. And so I understand Senator Eaton's concern, but I do like the more in-depth recording, measurement, data that will follow having this placed in the statute 198, in the $5 million grant statute.
Senator Wickland.
Thank you, Mr. Chair. I just wanted to say that I oppose the oral amendment, and I don't think that we should be taking away from a limited pool of money that has many uses already laid out for it. And I would not want to displace those because I think they're all vital to the work that we're doing to try to reduce health disparities. Thank you.
Mr. Chair.
Yeah, Senator Benson.
Mr. Chair, the general fund is also a limited pool of money, contrary to rumor. There is a limited pool of money, and I think it is very appropriate that something that is focused on core health equity and requires evidence-based processes go to a grant that is designed to do that. We are really good at, and I'm guilty of this, and there are several people who have a great idea, and let's just put $200,000 there, and they make little silos all over the place. Look at the back of your budget books, members. There are grants for all kinds of great ideas that have 200,000 here and some 50,000, and instead of putting them all in one place where eyes can be kept on them and they can see if they actually work together, we create little silos. And so it makes much more sense to have this placed within the health equity grants that already exist, that already have a structure, that actually already have administration for managing it. So I support the Nelson amendment to the A6 as described by Ms. Kavanaugh.
Members, I would like to vote on this oral amendment, but Senator Nelson, you still have your hand up. Do you have any comments before we vote?
No, Mr. Chair. Thank you so much.
Okay. Members, we have the oral amendment to the A6 in front of us. So please turn on your cameras and put your sound on. We are voting on the oral amendment to the A6. All in favor, say aye.
Aye.
Opposed, nay.
No.
Motion carried. The oral amendment is adopted to the A6. To the A6, Senator Eaton.
I would just encourage support.
Members, any other comments or questions to the A6 as amended?
Mr. Chair, I'll take the A6 as amended as a friendly amendment.
Thank you, Senator Benson. So members, we are voting on the amended A6. All in favor, say aye.
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 Any opposed, nay? Amendment passes. Senator Benson, any other amendments that you have?
Mr. Chair, I know that there are other amendments. I'm waiting for, there we go, Senator Eaton.
Okay, Senator Eaton.
Thank you. I have the, which one is it? A14.
Members, we are at the A14. I'm going to pull that up. Would you like to
Sure.
describe the A14, Senator Eaton?
A14 is an amendment to restore the Office of Medical Cannabis General Fund appropriation for the state of Minnesota. The cut of the $781,000 would result in the cut of 7 to 10 of the 17 FTEs in the department, which is like 40% of the staff, which would, you know, right now their current turnaround for applications is 48 hours, although they do have 30 days by statute, but it would be cause a drastic delay for patient wait times. Especially so if they were only able to draw from the state government special revenue fund. There are 32,000 patients who are served by this program, and the majority have intractable pain, post-traumatic stress disorder, cancer, and other conditions. So delaying relief under this program would hurt Minnesotans. And I think cutting the funds to this program is doesn't make sense to me.
Thank you, Senator Eaton. Senator Benson, did you have any comments before we go to general questions?
Thank you, Mr. Chair. There were research dollars given to the Office of Medical Cannabis, and given the expansion of medical cannabis across the country and the legalization efforts across the country, cannabis research is being done in many places beyond the Minnesota Department of Health. And so given that there's been an uptick in research in other places, funding research that is just at the Department of Health doesn't seem like the most efficient use of taxpayer dollars, and I think it could be spent in other places.
Thank you, Senator Benson. Senator Eaton.
I'd like to ask for a roll call vote.
Roll call has been requested and granted. Senator Wickland.
Thank you, Mr. Chair. Just wanted to speak in support of Senator Eaton's amendment, and I think that we've heard quite loudly and strongly from the patients using the existing program that the costs are too high, and by displacing this money, it would force the Department of Health to pass along extra costs to, as possibility, it would force them to either use, as Senator Benson said, some money for research, which I would not support, diverting money away from research that they're doing. And if it were passed along to the patients as extra cost, it would make an already unaffordable program more unaffordable, and I don't think that's the direction we should be going. This is a time when we are not in a budget deficit, we have a surplus, and to remove the funding and just expect that appropriate things are not going to be done within, excuse me, within the office. I don't think that that's the right expectation. I think that if they are doing research, they have responsibilities for the state program that requires individualized research for our state and for the needs that we have here in Minnesota, and they need to be able to continue to do that. So I support Senator Eaton's amendment. Thank you.
Thank you, Senator Wickland. Senator Eaton.
Thank you, Mr. Chair. I just wanted to add that I'm sure you're aware that patients who use this program, it's not covered under their insurance. And right now the average 30-day cost, or at least it was in 2019, was $316. And a lot, so it's already pretty much not available for people in the lower economic brackets. So it's a, by making it more expensive, we actually exclude more people from being able to use the program.
Thank you, Senator Eaton. Members, any other questions or comments?
Mr. Chair,
Senator Benson.
I think it's important to remember that there is a special revenue that at the beginning was intended to support the medical cannabis program. Research dollars were given at the time the bill was passed because there wasn't a lot of research that was going on. There is an expanding body of non-state funded research, and the Office of Medical Cannabis wasn't established to do research. It was to administer a program. And I'd also like to remind members that the legislative auditor took a good look at the Office of Medical Cannabis. They're undergoing, they need to get their house in a little bit better order. And I think it's time for us to do a reform of the Office of Medical Cannabis. We did significant work in this committee to make the program more affordable. And I think by doing these two things in conjunction, it's important that we not leave general fund money sitting where a private entity would be of better use. And the Office of Medical Cannabis was always intended to be standalone and not have ongoing general fund support.
Senator Abler.
Oh, thanks. And my phone's at 3%. I'm about to go inside and change my connection, but just want to ask a question. I don't have the amendment in front of me. Was this a general fund request?
Senator Eaton.
Yes, okay. It has come from the general fund in the past, and I want it to continue.
Yeah, so my question is just more technical, and I don't know for the chair or who, but we're discussing spending general fund. We have a general fund target for the bill. The money, I believe, is all spent, at least we did yesterday. And so do we have to have an offsetting reduction to pay for something new in any of these amendments? And I don't know the answer, so I'm just asking the question.
Senator Benson.
Mr. Chair and Senator Abler, I think Senator Eaton would be requesting a target adjustment.
Senator Abler.
Which is
that how it works?
Which is not going to happen. Senator Abler, I don't want you to, go out there with the idea that you just get to request a target adjustment.
This is some of the best news I've had in a long time, Madam Chair. Thank you. I'm going to go plug my phone in and think about it.
So no,
Thank you.
there will be no target adjustment. I'm asking for a no vote, but there are reasons that I put this in my spreadsheet. It wasn't cavalier. It was because there needs to be some work done at the Office of Medical Cannabis. It was intended to be a standalone entity. We do this with medical boards. That's why this language is here.
Thank you, Senator Benson. Senator Klein.
Well, thank you, Mr. Chair. And I just wanted to respond to Senator Abler. I think Senator Abler has held a gavel long enough that he fully knows that in committee we can offer bills which raise the cost of a bill. We can offer amendments which raise the cost of a bill. until we reach the floor. The fact remains that the target is set by men and can be adjusted by men. It is not something fixed in nature or set in the stars. And I don't think Senator Eaton nor myself feel responsible for the target that's been set. In fact, we would have set a very different one. So I support the amendment.
Thank you, Senator Klein. Senator Wickland.
Mr. Chair,
Senator Benson.
if I could briefly, Senator Klein, I believe I recall Senator Marty saying those exact words. It was not set by the stars, and so you have learned well.
Senator Wickland.
I guess I just wanted to make a comment. I don't recall that when we heard the bills earlier this session that were related to the medical cannabis program, there were some changes that we heard and some improvements, but I don't recall hearing reform in terms of making the office move to become more of a standalone entity. And I don't, I guess I would just appreciate if we are going to discuss that as a target and ask for input on where are you in moving towards that work, if it is a common understanding that it is supposed to be a standalone entity. I think we should have more time for discussion about that and hear from the department and the entity itself on where they are on that path and if that's a common understanding that that's the goal. So that's my comment. Thank you.
Thank you, Senator Wickland. Senator Benson.
I have no further comment, Mr. Chair.
Okay. Anybody else have any comments to the A14 amendment? If not, we are going to vote on the A14. Please turn on your cameras.
Roll
and
call
your
was requested. Roll call was requested.
Oh, I'm sorry. You're absolutely right. Thank you, Senator Klein. Roll call will go to our John there to take the roll call.
On the adoption of the A14 amendment, Senator Benson,
No.
Senator Draheim,
No.
Senator Wickland,
Yes.
Senator Abler,
No.
Senator Eaton,
Yes.
Senator Klein,
Yes.
Senator Curran,
No.
Senator Nelson,
No.
Senator Rosen.
No.
The report of the votes on the A14 amendment are 3 ayes and 6 nays.
Thank you. Members, the A14 did not pass. Do we have other amendments to the Bill 2360? Senator Wickland.
Thank you, Mr. Chair. I'd like to offer the A13 amendment.
A13 amendment. Let me bring that up. As I do, can you please explain the A13?
Thank you, Mr. Chair. Yes, this amendment is to restore to the Department of Health their operating adjustment request. It would be $781,000 in fiscal year 2022 and $1,219,000 in fiscal year 2023. This would be for agency operations. The reason I'm bringing this amendment forward, I believe that not funding the operating adjustment at this time when we are continuing to work through a serious public health emergency and pandemic, it's really not the time that we should be restricting or constraining the operating funds that the Department of Health has. They've been working around the clock to keep Minnesotans safe and not having adequate funding for doing all of the operations that they have responsibility for would have serious consequences for our state. And if they do not receive sufficient operating adjustment, I'm concerned about what choices they would have to make in terms of making cuts to their agency COVID has put our Department of Health in a very keen spotlight this year. All of the work that they had been doing prior to the pandemic, it was critical work, and now they have enhanced functions that they need to cover. They are responsible for monitoring, always monitoring infectious diseases. They are responsible for inspecting the quality of water and food. They are running immunization programs for preventable diseases that we wish to continue containing in Minnesota. That goes beyond what we are seeing with the COVID vaccination program. And they are responsible for monitoring care that are provided at nursing homes, hospitals, and other facilities, and WIC and maternal and child health services. They are responsible for new areas of licensure coming up, having to do with assisted living. I think that all of these are critical, and it really is important that we recognize that ongoing work needs continued funding and for operational purposes, and that inflation plays a role in budgets, that the cost of the things that they need to procure and the staff, it is affected by inflation, and we need to provide for an operating adjustment. So that is the reason I'm bringing this amendment forward today. Thank you.
Thank you, Senator Wickland. Senator Benson.
Thank you, Mr. Chair, and I need to correct one of Senator Wickland's statements. This isn't a restoration. There are no cuts made to the Department of Health. This is not a restoration. And so anyone who wants to characterize a no vote on this amendment as failing to support the Department of Health is just making things up out of whole cloth. We did raise SGSR for the new licensing. That is coming forward. We did that during a special session because that work is important. We have, the last time I did a health budget, I included out of the gate increasing fees so that they could continue to do clean water work. We're increasing fees for radiation inspections. I care what happens to this department. I did not put an operating adjustment in. I understand that the department may have increasing costs as we go forward, but I also know that in a changing work environment, for example, telecommuting, they might have some adjustment to their operations that will happen after they've all had time to take a week or two of vacation as we recover from this pandemic. They have done absolutely incredible work over the last year, and we should all be grateful. But I also think this committee should know that I asked how much of our general fund spending was supplanted by federal funds. The number is material. The number is more than the cost of this amendment, but I need it defined, and I need it brought to this committee. And I need it documented so that I know exactly what is going on with the department. At the beginning of requests for targets, I said, don't make cuts to MDH. I can't do that. That was part of my request to my leadership. So I will defend this department, but I also need to hold them accountable. So I've been asking for the federal funds supplanting general funds for quite a while. I did have a good discussion yesterday, the beginning of a more transparent communication about how federal funds are working in the Department of Health. We have a good working relationship. I will continue to make sure they are ready for COVID response to whatever extent is necessary. But today is not the day for this appropriation. I will find the federal money that I need answered. I will have a better understanding of how FEMA reimbursements are going to feed into the department over the coming months. So members, I'm going to ask you to vote no on this because we're going to have accountability and support.
Thank you, Senator Benson. Senator Wickland, do you want to go first or should I go to Senator Eaton?
Thank you, Mr. Chair. I just wanted to comment that I think there's different ways you can say it, but if we are taking a target that allows for zero growth, that is constraining the growth that would be accounted for in an operating adjustment. So you can say it's not a cut, but I mean, in reality, if it's money that they aren't able to have available for operating expenses, that to me is a reduction. So thank you.
Thank you, Senator Eaton.
Thank you, Mr. Chair. Well, kind of on the same lines, I would like to say that this seems like if they need an operating adjustment of this amount, then cutting it or not giving it is cutting it. And we just, was it last year or the year before, increased their funding by about 3 million, which is pretty equivalent to this, so because of the concerns we had that they didn't have the funding to deal with our seniors in long-term care and nursing homes and all the issues that were going on with that. So I just see this as a we gave them 3 million, now we're taking it back. I mean, I just think it's a bad idea.
Thank you, Senator Eaton. I'll make one quick comment here before we go on to other members. I was in college a long time. I took a lot of accounting courses, and this wouldn't be a cut by my definition, what I was taught at Mankato State. But anyway, Senator Benson, any more comments on this amendment? We are on the A13 amendment. Any other comments? Otherwise, we will vote. Please turn on your cameras and your microphones. So all in favor of the A13, say aye.
Aye.
All opposed, nay.
No.
Nay.
No.
Motion fails. The A13 is not adopted. Thank you, members. Any other amendments? Senator Wickland.
Sorry, Mr. Chair, I was trying to raise my hand. I have one more amendment.
Okay.
The A12 amendment.
Okay. Let me pull that up. As I do you want to describe your A12 amendment?
Yeah, the A12 amendment relates to out-of-pocket maximum or cost-sharing requirements. It would require health plans to count the patient assistance program payments towards cost sharing. We had discussion about something, a similar provision that I believe maybe you, Mr. Chair, brought forward. This particular provision would require a health plan to disclose whether payments towards your provision required health plans to disclose whether payments towards patient assistance programs would count against their deductible. But just requiring disclosure really doesn't help the patients make their health plan and their health costs more affordable. The proposal in this amendment, it would establish a practice where that would provide protection that this would count against their out-of-pocket, their cost sharing, and that then they would not be facing additional need to fill their deductible and their other out-of-pocket maximum after they have expended money on patient assistance programs. Basically, patient assistance programs are helpful to patients, but they come with costs. And if those costs don't count against the patient deductible, then they would be forced to pay that additional money to meet their deductible or co-pays later on. And so I believe that in fairness to patients, to improve the patient, reduce patient out-of-pocket expenses, this is one way we can address that in a way that would help those who have significant monthly out-of-pocket costs. And that's the amendment I brought forward. Thank you.
Thank you, Senator Wickland. Senator Benson, would you like to make any comments? Otherwise, I see we have a hand up. I could go to.
Mr. Chair, I understand where Senator Wickland's going with this. I liked your disclosure language. I think this goes farther than I am ready to. So I know why she's doing this. And consumers who pay out of pocket, Mr. Chair, you know very well what happens to them. But I think this needs to be a collaborative effort. And I just want to remind the public who might still be watching on a Friday afternoon, this doesn't apply to large employers. Public programs don't have cost-sharing reductions. The frustration that's building out there is sometimes about the confusion about who covers you. Mr. Andreessen is with the Council on Health Plans. I hope that they can help us work towards some sort of collaborative answer, but today is not the day for the 812. I'm going to ask for a no vote, but I'm going to let Mr. Andreessen, as one of the stakeholders, give us some feedback.
Mr. Andreessen, please state your name for the record.
Thank you, Mr. Chair, members of the committee. My name is Dan Andreessen with the Minnesota Council of Health Plans. And yeah, we're willing to work with Senator Wickland here in the future. It is about manufacturer coupons, which is a bit of a complicated system. Although these coupons are being used to help patients pay for that particular drug, they're also being used by manufacturers to keep that person using that particular drug. And it sometimes has a consequence of incentivizing the use of an expensive drug when there may be a cheaper one available on the market. And so we've urged manufacturers to lower prices for everyone rather than using coupons for a few. And also, we just want to point out that this could cause some tax implications for those using HSAs. Those who use an HSA through a high deductible plan are granted a tax benefit, assuming that they're paying for all of that deductible. So in the case of these coupons, a third party is the one helping to pay towards that deductible. So there may be some implications there. And so Delphi would like to work with Senator Wickland more on this, but we do have some pretty serious concerns with this language. Thank you.
Thank you. Senator Klein, would you like to go first, or should I call on Senator Wickland?
I'll go after Senator Wickland.
Okay, Senator Wickland.
Oh, thank you, Mr. Chair. I just wanted to state that, it may be true that there are manufacturers who have drugs that they want to use these patient assistance programs to help connect people with that drug longer. And maybe there are cases where that is advised that they seek out their physician's, advice on that. And it's not intended to prolong use of something where another drug that's more effective or cost effective could be used. However, I do know through a lot of the work that we did over the last couple of years on insulin that people do have preferences with insulin that are justified by their experiences, and that they seek out these patient assistance programs because the cost of insulin is just inordinately high. It's just beyond what it should cost. And so those who are able to help, reduce the cost that they're spending each month through a coupon, they do so, but they still have a lot of other expenses each month. And to not count that payment towards their deductible and other out-of-pocket maximum, it really has a negative impact on them, making choices on how do they cover their costs. So I would be happy to work on this more. This amendment is drafted after a law that's been put in place in Virginia. It offers similar protections. Arizona, Illinois, and West Virginia are also states where they have passed or are working on this type of legislation. And so I would very strongly like to keep working on it if it's not something that can move forward at this time. Thank you.
Thank you, Senator Wickland. Senator Klein.
Thank you, Mr. Chair. And I just find myself, like Senator Wickland, in full agreement with the Council of Health Plans that these coupons and other incentives often are used perversely to maintain consumers on obsolete or expensive drugs, and we should be doing better. The solution to that is for the immense power of the health plans to push back against pharmaceutical companies or remove those drugs from their formularies, not to leave the consumer or the patient holding the stick with a higher copay at the end of their payment year. So of all the mechanisms that we have to correct that problem, perverse incentives created by coupons, sort of making a individual patient pay their full copay that year is not the solution. So I support the amendment.
Thank you, Senator Klein. Senator Abler.
Yeah, thank you. I've just got a question for Mr. Andreessen. And I wish this could have come up earlier so we could have sorted through it a little bit. Because I think I like the idea, but I'm nervous to vote for something on the fly. But so Mr. Andreessen, I understand, we're back to all the concern from Washington and tax implications and holy cow, we care about the patients. But this one, I don't know. So I presume that when the insulin program in Minnesota kicked in, that you reduced your capitations to cover the expected savings you'd be getting from people that wouldn't be accessing insulin from your plans. I would just presume that. Is that true?
Mr. Andreessen.
Mr. Chair, Senator Abler, I guess I'm confused. You mean capitation? Because many of our
your premiums. Did a person? I mean, your actuaries sit around in the rooms and they do math and they expect that people are going to incur a certain amount of cost. And if you take on a person with diabetes as one of your persons, they're going to incur a certain amount of cost just every year, and then you average that out, and you get a premium for whatever population group or a company. But now here comes a program where they don't have to pay for that anymore, and so suddenly the beneficiary is the individual who maybe has lower cost sharings, but also the beneficiary, if you don't reduce your premiums, the beneficiary is the health plan, which doesn't have that high cost person anymore to pay for their insulin. So when you set your premiums for whatever group, do you take into consideration the reduced cost you're going to have because there is a patient assistant program?
Mr. Andreessen.
Mr. Chair, Senator Abler, I think when our folks set their premiums and deductibles and copays, it's under the assumption that the patient is the one who's paying for those.
Senator Abler.
Right, exactly. And so you don't really care who covers, so you don't change your premiums at all. And so if the person finds another way to satisfy the cost that you've already actuarially decided, then the health plan should be agnostic about who helps to pay for that. And if indeed they would have not had the patient assistance program in place, they would have had to pay more money, which would have gotten them to their deductible and so on. I'm just pointing out that there's a lot of inconsistency here, and this really needs to be explored and worked on. I think it's a great idea. I think there's probably some things we need to sort through now, and this should actually has to go to Commerce if we're going to work on it to do it correctly. But I think you're onto an idea that we need to pursue, and I think the health plan should take into consideration the fact that there's going to be some of these costs covered, because in the health plan actuary, they consider the deductible to be part of the 70% or whatever, the 30% that the person is paying if they have a silver plan. So anyway, thanks for that. I feel enlightened. Thanks a lot.
Thank you, Senator Abler. Any other questions to the E12 amendment? Senator Wickland?
Thank you, Mr. Chair. I think, I understand that this is a complex area and a complex amendment to bring forward and to think through all of the implications and whether we could tailor it to more specific areas if I had more discussion. I would like to continue to work on it. And so for today, I guess I would prefer to withdraw the amendment and then to continue to have more discussion with the health plans and with other stakeholders to see if there's a way that we can really get at addressing the out-of-pocket costs for patients in Minnesota and do it in a way that's meaningful. And because we know that prescription drug costs are such a large, have a large impact on people's budgets. So for today, I will withdraw the amendment. Thank you.
Thank you, Senator Wickland.
And Mr. Chair, I
Senator
do
Benson.
want to thank Senator Wickland because the interactivity of formularies and mandated rebates and negotiated rebates, volume-based purchasing and coupons is really complicated. And if we're going to have a solution, it's going to be through really collaborative work that's brought to this committee and then vetted in a really rigorous way. That doesn't mean it can't happen. It's just not going to be simple. And so I'm grateful that she's keeping the idea alive, but withdrew the amendment today because this is not going to be simple.
Thank you, Senator Benson. Members, any other amendments to Senate File 2360? I'm not seeing any amendments, Senator Benson. Any other comments towards 2360? Otherwise, we'll go to Senator Klein.
Thank you, Mr. Chair, and thank you for leading a good walkthrough of the bill and hearing all our amendments. Thank you to the author of the bill, Senator Benson, for also hearing our amendments and being receptive to the ideas of the minority party as we work forward. There are some excellent things in this omnibus bill, in particular, sort of the groundbreaking progress on coverage for medical assistance after childbirth will have a real impact, I believe, on racial disparities in our state and on maternal health outcomes. So thank you very much for that provision. I also appreciate your thoughtfulness about being willing to consider recuperative health homes going forward yet this session. I am going to be a no vote on this bill, and I just wanted to sort of explain that briefly. I think fundamentally, we on this side of the aisle, and me in particular, disagree with the target. As our aging population, as our disabled population continues to grow in a quantity that we can measure each year, as we face a crisis of racial disparities and health outcomes in our state, now is not the time to cut funding or even to stabilize funding in healthcare delivery in our state. In a time of surplus and in a time of federal subsidies, now is not the time to solve the HHS budget with shifts or shifts onto the next biennium or gimmicks, I guess some people would say. And so this is a time to budget responsibly and budget planfully for the issues that are facing our state. And that explains my no vote. And thank you, Mr. Chair.
Thank you, Senator Klein. Any other comments to the 2360? Senator Wickland.
Thank you, Mr. Chair. Thank you for having an opportunity for us to go through the bill and make some amendments or bring forward some amendments that we thought were particularly important to discuss today. I want to say a few things about the bill and some of the strengths I see and also some of the weaknesses. I mean, in terms of the area of maternal health, I really do think that the bill has some significant provisions in it that will be helpful to women in Minnesota. Certainly the most that stands out the most is the provision for Medicaid coverage for the 180 days. I think that will have a positive impact on mothers' health and also their children. I would say that I do support really the full year coverage, and I believe looking at the fiscal note and talking with DHS staff about the reasons for the costs to implement the program. I think that our balancing of cost and value to residents of Minnesota, I think we should really look at whether the 12 months coverage would be more value for us. There is significant work that needs to happen in the systems that support our Medicaid population. And I would be just disappointed if we put a lot of this work into that system and then made a change to 12 months and then have to have an incremental additional systems cost. Also, there is significant work that requires people to go in and examine enrollees and move people around. And I just think we should try to be as efficient as we can about how we use the dollars to support these Medicaid programs. So, and I think the health benefits to mothers for a full year of coverage along with their infant really makes more sense. So that would be my one caveat on that. I think in terms of missing items in the bill relating to maternal health, there are some missing portions of the work that the other body is doing in terms of maternal health disparities. And I hope that those will be strongly considered as the bill moves forward. There's inclusion of the Department of Health, maternal mortality, and morbidity provisions, which I think I agree that the report that Senator Benson has discussed would be helpful to us, but I do think that our capturing information about maternal health mortality and expanding to morbidity is something that would be beneficial as well, especially as we try to do some research on what are the causes of the maternal health disparities. So I hope that those will be considered going forward. In terms of health coverage, the other body has include some proposals on how we can move forward with other ideas relating to health insurance, reporting on payments, how we could structure a public option, and studying that. I think that work is important to address. I know that the Commerce Committee has moved forward a reinsurance item that would extend for an additional year beyond the year that we already approved. I really think that we should be looking at what are alternatives and how can we best assure that Minnesotans have access to an individual market and just better access to health coverage. So I would hope that you would take a look at those. And I think there are some provisions in here that I'm not sure really add value for Minnesotans. The requirement to use an in-state pharmacy, I'm not convinced that expense of money to implement that is really going to benefit Minnesotans a great deal, and it could cause some negative impacts on Minnesotans who have to access pharmacies outside of Minnesota. And the tobacco use premium concept to the surcharge, I think, would have a negative impact on people who need support in making sure that they continue to have access to the other programs within medical assistance. I don't think shifting additional cost to tobacco users is going to have the desired outcome. And lastly, I just wanted to say I really have concerns about the budget methodology used in the bill, and shifting the capitation payments into the next biennium. it shifts, concern for that next planning cycle. I realize that, again, the shift goes on for another biennium. It shifts it out again so that the intervening legislature isn't dealing with it. But I just don't think that that's a very good way for us to do our budgeting, especially at a time when we have sufficient resources available to deal with our budget this year. If things were different, we were trying to find any way to manage a budget crisis, maybe shifting to a different biennium is a possibility, but I don't think it's the right one for this year. It's not savings, it's just moving the money or moving the cost, just moving it to the next year. So I really have strong concerns about that. Concerns about the lack of operational support for the agencies. And I'm not going to be able to support the bill today, but I hope that we continue to work together and work on ways to make the bill stronger as it goes forward and provide additional changes to the bill. So thank you.
Thank you, Senator Wickland. Senator Klein, I see you still have your hand up. Do you still have comments you wanted to make? Okay, thank you. Members, any other comments? Otherwise, I'm going to go to Senator Benson for final thoughts. Senator Abler.
Well, yeah, just briefly, it's really weird doing this by Zoom. It just seems like I don't know. It just seems really weird, and it doesn't seem like it's even really an omnibus. Like yesterday was the same. It was just unreal. So I look forward to doing some of this in person, where we actually can look at each other across the table, and you can go back and chat sideways with anybody you want. And so I think that we really have suffered this year for that. And even just talking now all together on some of these topics, where some things were great ideas but not quite ready, or from either side of the aisle, we've really missed some of that. And I think, with all respect to everybody who had a hand in this, I think part of the product of this session as a whole is going to be lacking some of those really innovative ideas and collaborative thoughts, which we got into a little bit on your bill, Senator Draheim, and we actually had some good dialogue, but still in a Zoom format. All that being said, I think the people of Minnesota really count on us. And I think if it weren't for committees like ours, even though we don't always agree, but if it weren't for what we do here, there would be way less pharmacies in greater Minnesota. There would be way less people getting the healthcare they need in all walks of Minnesota life if it weren't for this kind of a process. I think that one thing that we're clear on, that we agree generally, is that we care about the people. And I think left to itself, the big conglomerate healthcare industry is going to get bigger and bigger and suppress more and more the individuality of the doctors, even the kinds they can choose, how much they can see them, where they have to go. And I think that that's something we want to keep in mind, that this committee, in particular on this topic, on the healthcare side, is what is the firewall between just the total loss of all those freedoms and opportunities. And I think what we've become is kind of the conscience of some of these larger entities. And I have nothing against PBMs or health plans or any big pharma or any of that necessarily. But when they, in all their mission statements, they say somewhere we care about people, making them healthy, it's our job to serve, or something like that. And I think it's our job to remind them of that as we go through these topics. And just since I singled out your amendment, Senator Draheim, I think topics like that provide a check and a balance. And I think this idea about patient assistance programs, we need to talk about that. Otherwise, it's hard to show that up on the bottom line of any spreadsheet or one of our bills, but incrementally it makes a difference. And it might be the incremental difference a family has in deciding to keep their insurance or being able to access it for something else they got sick from. So I'm commending all of us for what we're trying to do. We have a lot of work ahead, but I think at the end, this is going to be a pretty reasonable, modest bill with all the parts combined. And Minnesota, I think, can be well served by the dialogue and the respect shown in the debate today here. So anyway, thank you for all that. And I guess that's just a comment in general, and I'll be voting yes for the bill because the process has to go forward. We need this bill to pass and get into the loop. And at the end, I think hopefully everybody can vote for it. And I hope that even more can vote for it, on the floor, just to encourage the process. Because I think Minnesota is looking for that. They want us to work together. And I think that we can do that. Thanks a lot.
Thanks, Senator Abler. Any other comments to the 2360? Senator Benson.
Mr. Chair, thank you. I think there's some good work in here, moving dental to a more accountable place for MA recipients, focusing on the stability of pharmacy in our state. Telehealth isn't in here. It's being worked on. We need to leave some room in our target for that. Opioids, we did really good collaborative work. This committee is really dedicated to trying to do the right thing. We did increase public health spending, and yes, people don't like that it came out of SHIP, but I'd rather just give them the money than make them do a bunch of paperwork and explain that they're going to do good work. Just give them the money and let them do good work. I want to thank Senator Klein and Senator Wickland for pointing out the shift, the payment delay. It is the thing that bothers me the most. I am trying to find the money that pushed into the departments, FEMA reimbursement. So we've spent a lot of money on COVID response, and we're getting more and more reimbursement on that. I'm trying to find a way to do this straight and not have that shift involved. I would rather have us make decisions on how latent money coming into the system is spent than have it show up in July and then be roped into the November forecast. And so I'm trying to be thoughtful about that. But for today, in order to meet this target, there is a payment delay. And it is not lost on me that there's better practice involved in doing this work. So I appreciate the candid nature of those who disagree with that policy provision, and the others. There is work to be done everywhere. I didn't think this was going to happen. Ms. Strand, before I cry, I need to thank our staff. Mr. Albrecht, Ms. Kavanaugh, Mr. Monahan, Mr. Huswald, Ms. Strang, Ms. Fisher, Mr. Osterlin, our pages who make our virtual sessions work, and all of you. I am very grateful. But you know what happens when you don't meet in person for a year and then your CA cleans out her folder? She finds a research document from February 18th, 2020. It starts out, members, you've heard of an outbreak of a new and deadly virus that originated in China. The virus can lead to pneumonia or breathing difficulties. More rarely, that disease can be fatal. As of February 18th, 2020, the United States had 15 confirmed cases. 13 of those cases had a travel history from China. So we have come through a lot together, members. And regardless of how you vote on this bill, I'm grateful for the journey with you. You have done good work for the people of Minnesota. To the folks at the Department of Health, no, your increase isn't in here, but I've walked every step of the way with you, and I want you to do good work in an accountable, transparent way for the people of Minnesota. You have served them well. To the people in public health, you got money because you proved you are the Swiss Army knife of health response. To our hospitals and all of our care providers, I have tried to stand in the gap where I needed to and get out of the way where I could. So regardless of how you vote or what do you think of my budget, I am grateful. Thank you. So, Mr. Chair, can we move that Senate File 2360, sorry, I'm having a little trouble reading, as amended, be recommended to pass and sent to the Committee on Finance?
Yes, we will vote right now, members, on 2360 as amended to be re-referred to Finance Committee. So please have your cameras on, your microphones on. All in favor of the 2360 as amended, say aye.
Aye.
Opposed, nay?
Nay.
Okay.
Your bill passes. Senator Benson, thank you for all your hard work and the staff and all the members. I've really enjoyed this year with everyone. So thank you. I'll hand the gavel back to you, Senator Benson.
Thank you, Senator Draheim. We might be having some other hearings. As you know, the work is not going to stop in pandemic response, and so we will keep you posted on those hearings. I believe we'll be up in Finance next week and then on the floor in the following weeks. I thank you for your work, and with that, members, we are adjourned.